Can you hear me well?
Yes, we can hear you well.
Thank you, Kevin.
How are you, Christian?
Not too bad. Thank you again, Kevin, to let us present on ECMO at the surgical grand round.
Don't worry, we're looking forward to it.
Perfect. Just say I'm going to present, as you know, with Dr. Bracco, Dr. Martucci.
Yeah.
And
So why don't I just make the introductions and then we'll let you get going. So I think it's 7:30 and we should, I think everyone that needs to be on the conference is there, so that's good. So good morning, everybody, and thank you again for attending Surgical Grand Rounds. The attendance is usually quite good, so keep it up, please. Thank you for supporting our colleagues and also supporting the department. Today we have Dr. Sirois, thoracic surgeon from the Montreal General, Dr. David Bracco, anesthetist from the Montreal General, Dr. Joe Martucci, cardiologist at the Royal Victoria Hospital, and Dr. Gordan Samoukovic, intensivist at the Royal Vic and kind of a traveling ECMO guy, I guess. Anyway, they've put together a talk as a multidisciplinary approach to ECMO, and we're looking forward to their talk and to the results for this program. So Christian, why don't you go ahead and get started, and I'll leave it up to you. I'll be managing the chat as well. So at the end, when we have some time for questions, I'll just go over it with you, okay?
Thank you, Kevin, for the introduction. And I just want to say that Joe texted us this morning. He's on call for cath lab, and he just got an emergency. So I hope he's not to call a code ECMO. So, but he hopefully will join us at some point. So here we go. I'm going to start. The learning objective, we will present a general overview of ECMO and including the indication, and obviously we'll present our experience of the MUHC ECMO program. These are the detailed outline of the presentation. And I would like to review some definition: ECMO, extracorporeal membrane oxygenation; ECLS, extracorporeal life support; ECPR, extracorporeal cardiopulmonary resuscitation; and CPB, cardiopulmonary bypass. This will come back toward the talk today. I will start with a quick case presentation. A patient was referred to me for lung cancer invading the trachea in 2012. He was a previous smoker and he didn't have any metastasis. You can clearly see the tumor invading the trachea near the carina. And we perform a right pneumonectomy with a tracheal sleeve resection and a muscle flap. At that time, John Spicer was our fellow. And I was explaining to John how to dissect meticulously the serratus muscle and to do not cut it before to perform the thoracotomy. So we save it and we perform the pneumonectomy. We use an infill tubing ventilation system, sterile, that we place directly in the left main bronchus. And this is connected to the ventilator with the help of the anesthetist. And then we perform a conventional end-sound anastomosis. And to cover the anastomosis to avoid a leak, I like to wrap the anastomosis with a nice LT muscle flap, which cover well the mediastinum. The patient did fantastic for a few days. Unfortunately, he developed some hypoxemia, and he also had a severe C. difficile colitis. As you recall, this was quite frequent in these days. He required, unfortunately, admission to the intensive care unit, and he had O2 requirement increase, and then he needed intubation. At some point, we were quite desperate what to do with him because he had the peak air pressure of 20, FiO2 100%, the PEEP of 20, peak air pressure of 40. That was pretty dramatic. And when you see so much hardware on a chest X-ray, it doesn't look good. Gordan Samoukovic was IC fellow at that time, and we decided to call cardiac surgery. Dr. Devine was on call, and Benoit came and placed immediately the patient on ECMO. Dr. Bracco was not on call, but he came to help and to place the cannula using transesophageal echo. In the middle of the night, Dr. Feldman performed a total colectomy. Dr. Mueller was followed this time, and surprisingly, against all odds, the patient stabilized and improved very quickly. 5 days later, the patient was weaned off ECMO. You can see the big, large ECMO cannula here that was removed, and a month later, the patient went home. That was quite a fascinating case. I was very impressed with this new ECMO machine, CardioL, made by a German company, McGill. This was a light, portable ECMO. There's only one was available, approved for transportation at that time. And in addition, I'm quite familiar with a double lumen endotracheal tube, but a double lumen venous jugular ECMO cannula, that was the first time I've seen that. So that was very fascinating case. And I recall that the first ECMO was performed in California in 71, and the first cell phone was in 73 in New York. I was fairly young at that time. But when I was resident, ECMO looks like this. It was kind of messy and bloody, and the survival was very poor. But now, these days, it's all touchscreen computerized. So I decided to do several courses on ECMO and get certification. I thought that would be useful for a pulmonary surgeon. As you can see, the ECMO principle is fairly simple compared to cardiopulmonary bypass. It's a one closed circuit. But you have to keep in mind that this is very important, that if you have bleeding, ECMO will not help you because it's a closed circuit and you really need cardiopulmonary bypass. From a historical perspective, both cardiopulmonary bypass and ECMO are closely related. The French did the first experimentation in 1693, and the Russian did some extracorporeal circulation in dog. However, John Gibbons from Philadelphia did the first successful extracorporeal circulation in a woman in 1953. He is credited for the invention of the heart-lung machine. Kennedy published the first survival of using cardiopulmonary bypass in cardiac arrest. It was a pulmonary emboli. This is the heart-lung machine of Gibbon. And this is a fascinating paper of Kennedy published in 1966. I'm quite impressed with his visionary impression and opinion about all the type of extracorporeal assist in cardiac arrest that we still use these days. He had a bubble oxygenator, prime, sterile, ready to go in case of an emergency. But as I mentioned, the first true ECMO, membrane oxygenation, was performed by Hill in 71 and by Bartlett on kids in 1975. In 1989, the extracorporeal life ELSO was founded, and the ECMO registry was started. So this is a classic paper of Hill, and a young 24 years old motorcycle trauma had ARDS, a shock lung syndrome, and the patient was supported by a membrane oxygenation for several days, and he survived. In 2009, several young patients developed a severe ARDS, and ECMO was helping those patients. A randomized controlled trial demonstrated improved survival, and since 2009, the use of ECMO increased. The red bar are the center, and the blue line is the ECMO case. Now, the statistics are usually published in January for the previous year. So we have the 2019 statistic, but we're still waiting for the 2020 statistic, which has been delayed due to the COVID pandemic. But we expect, obviously, a rise. As you may recall, last January, a young physician from Yuan tried to warn us about the coronavirus outbreak. Unfortunately, he developed ARDS and was placed on ECMO. He sadly passed away. I was shocked by this news, and I shared it with my colleague, and I was quite worried that this pandemic might be a problem since the capacity of ECMO is limited. As we know now, coronavirus affect mostly elderly patients, and we luckily didn't have a significant shortage of ECMO yet. Nevertheless, many patients with COVID are placed on ECMO, and these are the worldwide statistic. Roughly 50% of the patients die. The use of ECMO has increased over the last decade, and is another reason is mostly related to the advance of medical technology. To name few of those, a compact mobile centrifugal pump oxygenator, a fully integrated computerized circuit, rapid and simple priming process, heparin-coated tubing system, new generation in thin arterial and venous cannula, Seldinger percutaneous cannulation with ultrasound guidance, and facility of transportation. This is really a game changer for ECMO. ECMO was even used in some circumstances outside of the hospital, first in Paris at the Marathon in 2011, and in different situations in France and in Germany. This obviously is controversial. Meanwhile, in Montreal, in 2018, we had the ECMO capability set up in case of a cardiopulmonary arrest. This was a collaborative work with the Hôpital Sacré-Cœur, and David Bracco and François de Champlain were on the team as well. These are the general indications for ECMO. Dr. Bracco will review them in detail shortly, and he will also discuss the type of ECMO, VV, VA, or hybrid. But I would like that you pay attention to this slide. If you need extracorporeal support for oxygenation and ventilation, you would choose ECMO veno-venous, VV. If you suspect hemodynamic instability or cardiac arrest, you will choose ECMO VA, veno-arterial. But if you have a bleeding or you will perform surgery on cardiovascular structure, you really need conventional cardiopulmonary bypass. It's very important to make the distinction. In thoracic surgery, we use ECMO for airways, and this is quite useful. Different ECMO center has been selected in the province, 5 in Montreal and 3 in the rest of the province. I would like you pay attention to this important document published by INES in 2019, reviewing the use of ECMO. It's a very extensive document, and Gordan was on the committee for this publication. I want you understand that there's an ECMO team collaboration. It's very important. And this was also published by the Harvard group in 2019. They demonstrate improved survival with the formal ECMO team approach. I will let Dr. Bracco to carry on now and to describe this study. David? You're muted, I think.
David, okay, good morning. Sorry, my microphone was off. Thank you very much. Next slide, please.
Yes.
I want to tell you, this is also statistic, and when we know what we're doing pulmonary ECMO, we're doing cardiac ECMO or ECPR, and this is the statistic as of July 2020, and we'll compare this with our internal data. Next slide, please. Christian, show us. Next slide, please.
Yes.
Next, please, Christian.
Yes, yes.
Go ahead. This is the number of run, and this as of 2019. You see the number of run and the number of center are increasing. Next slide, please. There's been a discussion about COVID, and go down, please. Next slide. There has been next slide, please, Christian. There has been a discussion about ECMO and COVID and resource utilization, but it's actually, let's say, feasible. There's roughly 2 types of main configuration on the ECMO machine. One is what we call VV and what we call VA. There's always one inflow to the machine, the drainage cannula, which is always from the venous compartment, and there's one delivery cannula, which can be venous or arterial. There's other configuration like VVV when we add another venous for drainage, or VVA when we have 2 veins for drainage and 1 for infusion, and VAV. We'll talk a little bit about VAV and other configuration later. Next slide, please. The most classical configuration, next please, Christian. The most classical configuration is what we call a VV with a classical approach. And the VV with a classical approach, the drainage cannula is in the IVC, and a rim fusion is made from a shorter cannula in the right IJ, in the right atrium. Next slide. This is a IVC drainage cannula, which is placed at the IVC area junction. You see the liver, the IVC, the suprahepatic vein, and the cannula in IVC. That's where we drain. Next slide. And we reinfuse in the right atrium toward facing the tricuspid valve. So when we do percutaneous ECMO, by cardiac echo, transesophageal or transthoracic. Next slide, please. Next. Next slide, please. So next slide, please. And the classical approach can also be done by two femoral lines, where one drainage line is put in IVC area junction and the other line is put in the middle area for infusion. What we use most classically is this three-stage double lumen cannula, which is called Avalon cannula, which is placed in the right internal jugular and has a three-stage, two drainage stage, one in SVC, one in IVC, and one reinfusion stage in the array. Next slide, please. So these cannula are quite complex, have to be placed very carefully, not only in terms of depth, but also in terms of rotation and suction. But you see there is a multi-port drainage in IVC and in SVC, and there's a reinfusion cannula, as you can see on the right of your slide, in the array. Next slide, please. As you can see, this should be a video on the right, but the jet of the reinfusion has to be directed towards the tricuspid valve to decrease recirculation. And this has to be done very carefully. Next slide, please. Also, these cannula are quite tricky to put in place. There has been some complication described with this cannula going through the tricuspid or going at the wrong place. Next cannula. Next slide, please. The diameter is also, next please, the diameter is also very important. To achieve reasonable flow in adult, we need fairly large cannula. This is the second configuration, it's called VA. We drain from a femoral vein usually with a long catheter going in the middle of the array, as you can see on the right leg of this patient, and we reinfuse on with a short catheter in a iliac artery. We go down on a common femoral artery, dilate, and put a short infusion catheter in the middle of the iliac artery. You can also see on the second red arrow, we put a small catheter to perfuse the leg. If we don't do this, due to the diameter of the cannula and the flow directed upward, retrograde in aorta, you have no perfusion on the leg and you have leg ischemia complication. We'll talk about this later. Next slide, please. So this is a case we had with Gordan 1 or 2 years ago, was a influenza ARDS, and the guy was very big. We had not enough drainage, so we added, as you can see, from the left femoral vein, another drainage to go from VV to VVV. Next slide, please. The VAV configuration, we have a problem when this is on the left side of the drawing here. You have a classical VA configuration where we drain from the right atrium, we reinfuse in our arterial compartment. But if the patient recovers on the cardiac function but not on the lung function, you may have some cardiac output going through the lung and the aortic valve. And as you can see on a CT scan with contrast here, you have a kind of watershed area where you have desaturated blood coming out from the aortic valve and saturated blood coming retrograde in the aorta. And this can lead to cerebral ischemia and complication. To avoid this, next slide, please. You reinfuse a little part of the aortic blood, of the oxygenated blood, in the right atrium. And by doing this, the blood going through the lung will be oxygenated and you avoid the cerebral ischemia. Next slide, we'll talk a little bit about ECPR, which is cardiopulmonary resuscitation assisted with ECMO for refractory cases. If you look at the two society guideline from the European Resuscitation Council and from the AHA, this is ERC, which is a rescue therapy should be considered. Next slide, please. If you look at the ACLS guideline, ECPR may be considered, and then they have a few criteria which are variable from one center to another, but look at the class of the evidence. It's a recommendation to B, level of evidence C. Next slide, please. If we look at outcome on this type of patients, this is a propensity match cohort. So has this limitation with the propensity matching and other stuff, but you see that patient having ECPR for refractory cardiac arrest have a better outcome up to 1 year after the cardiac arrest. And the curve separate very immediately in the first 7 days, I would say. Next slide, please. If we look at, this is a cohort of in-hospital cardiac arrest, and you see the survival to discharge. In red, you have the ECPR group. In blue, you have the normal conventional resuscitation group. And if you look at the collapse to pump or collapse to ROSC in the blue group, if you are beyond 60-minute collapse to on pump, your survival is very low. So decision has to be made to go on if needed very, very rapidly. And all the chain behind this has to function very fast, since between the arrest and full support, we have 60-minute max. Next slide, please. Now, when you look at this in-hospital cardiac arrest, so a survival on weaning to ECMO, 50% get weaned from ECMO, 50% do not. But if you look at discharge of functional capacity as discharge of functional capacity at 1 year, the results are not gorgeous, I would say, but there is still a 30% discharge and 24% discharge with a correct cerebral performance score. And next slide, please. This is Paris, a PTA experience on cardiac arrest, and they have a 1 year survival of 35 patients on roughly 400 patients on ECPR. Next slide, please. Christian told you a little bit about going on the street to do ECMO. This is a case they did on a Paris Metro. Next slide, they also did a very publicized case at the Louvre. So if you want to visit the Louvre, you may remember this slide here. Next slide, please. Next, Christian, please. So if you look at the classical ECPR criteria, we have some criteria in-house there. This one is the Australian one, but roughly the arrest has to be witnessed, CPR immediately, and there's some special consideration of people who may benefit from this, like hypothermic patient, intoxicated patient with beta blocker or calcium channel blocker or this type of drugs, which may respond myocarditis, postpartum cardiomyopathy, pulmonary embolism, amniotic fluid embolism. These are the kind of patient who better respond to this. Acute coronary event also, if we tandem them with PCI and this type of stuff. There's some controversies in CPR in terms of benefit and risk. There's no very little randomized trial. There's a lot of logistic of implementation problem, of timing, financial aspect, and in terms of cost effectiveness. There's one trial in the H1 and one called the CESAR trial, shows that ECMO can be beneficial, but there's no randomized trial on ECPR or other support like that. Next slide, please. In terms of complication, there's, let's say, 3 groups of complication. One is the leg embolic event, leg event, where they can have ischemia, LEI, fasciotomies, require amputation, or this type of stuff. The second group is embolic with stroke, neurologic bleeding. And the third group of complication is bleeding complication due to cannula, access site, other sites, and anticoagulation. Next slide, please. So it's really a teamwork, and we work with a lot of people. First group is the perfusionists, which are in get a real experience in nursing of this type of patient, especially ICU gland, and a multidisciplinary group of cannulator people supporting this, etc. Next slide, please. I would especially, next please, Christian. I would say a special thank you to the group of perfusion. These 10 people man a 3-side 24/7, and they deserve a well-deserved round of applause. From now on, I'll pass it to Dr. Martucci, who will tell you a little bit more what's going on in a cath lab and how can the bypass help in a cath lab. Thank you.
Are you there, Joe?
Christian? Joe is there, or Gord, you want to take over?
You know what? Why don't we just go to my section, Christian, and I hopefully Joe will have finished by then, because I don't really want to take this away from him. It's really his baby. And what I'm going to talk about is a bit of a natural continuation of what David has mentioned, and I'm going to introduce you into the structure of the program at the MUHC and sort of give you an idea as to where we stand on the adult side. Our pediatric colleagues are approximately 2 light years ahead of us in terms of training and structure and everything else, and that program has been established very well and has been contributing to the ELSO database for a number of years, as a matter of fact. We're still in the early stages of all of that, but never, we're moving quite nicely forward, and I'm going to explain to you as to what has happened since I don't know, 3 years ago or so when we started doing this.
It looks weird.
What's happening?
No.
Hello? Somebody else is kicking into the presentation, so mute your microphones, please. Okay, so next slide, Christian, please. So these are the people who've been active with the team since inception. People have been added as we went along. The group of cannulators and people who support this program is immense. We've already mentioned our perfusion group, who's been nothing less than phenomenal over the years, stretching themselves far and beyond of any other group that does anything similar to this in Canada. We've now involved a lot of fellows in the program. Our cath lab group has been extremely involved. The group from anesthesia at MGH has been very, very active. Dr. Sarah Najmi was recruited and has come back from Duke to us and is probably going to be leading the extracorporeal program at the Montreal General, obviously with our support. First year today, we had, this year, we had a cardiovascular ICU / ECMO fellow, Dr. Ryan Koutoub, who's midway through his training, and so on and so on. This has been a very heavy project for all of us. I want to mention the undertakings of the perfusion group, along with Patricia Alfaro and Rita Laratonda on the nursing group, where we're creating the first nurse provider, ELSO provider training program to our nurses in order to offload the resource intensity that has come about upon our perfusion group. So we're heading in that direction, and we're going to be the first one in Quebec, certainly. In terms of our ECPR program, we're the only program in Canada that has a 24/7 ECPR coverage with at least 2 dedicated cannulators on call for both of our sites. In terms of Quebec, we run more ECMOs than all other centers combined nowadays. According to the latest data from 2020, we're probably first or second busiest center in Canada. So we've reached some interesting volumes. We have started a little bit of an outreach program with Ines. The word is being tossed around about mobile ECMO program in Quebec, and we're certainly participating in development of that. May Tam and Patricia Alfaro have been involved with Ines along myself and Dr. Sidorovitz in terms of involving us in these things. So I'm going to show you as to where this has led and what we've done. So next slide, please, David. So in terms of our quote unquote ECMO activations, like I said, we have a code ECMO that has been established for 2.5 years now, where physicians are now in a position to activate the code ECMO team, meaning that people will respond. In addition to that, we get elective referrals, meaning patients who are not crashing and so on and so on. And the third category is case planning, for example, for cases that would need ECMO support, whether that's an airway surgery, whether it's in something in the cath lab or an EP lab, as we most recently have done. We tend to respond to those requests as well, where hemodynamics or respiratory system is compromised, and we support the patients through the procedure that another healthcare provider is providing. The most important part here is that the vision of this program is to collaborate with the treating physician and to empower the treating physician to have an option to reach out to us, discuss the case, and make a decision regarding whether the patient is fit for cardiopulmonary support. We have established guidelines, and these guidelines are based on age, comorbidities, and so on and so on. As well, we've established protocols for emergency room activations, in particular for ECPR. And over the years, initially we had a bit of a wider net, I think, but now this is getting more and more refined. And we're still obviously leaving it to the treating physician to make decisions whether their patient is the most fit patient for ECMO or not. And we extend these criteria to meet the needs of the patient and the judgment of individual treating physicians occasionally in order to optimize patient care and to provide best possible care, obviously within limitations of resources and those guidelines. Next slide, please. So this data is probably just a little bit incomplete, and maybe we're on and off by a few numbers each year. This is provided to me and compiled by Jeanne Corriveau. She's one of our perfusionists who's been very much involved in the training and the academic endeavors of this program. And as you can see, since 2016, before the formalization of this program, we have seen a growth. I think the number of 2019 is actually incorrect. I think we did 55 runs. So unfortunately, Jeanne was not around, so her data here is probably incorrect, but I'll check that. As you can see, we've seen a steady rise of our cases, and I think it's partially because of we've become quite active, and we've been promoting the program, and people have become aware of us. And we've seen a little bit of a shift in 2020, 2019, 2020. We are traditionally a heavy VA center with a busy ECPR program. And due to the nature of our cardiac surgical practice, the complexity, we were more likely to see the cases of the VA nature in the past. There's been a bit of a shift in the paradigm in the last couple of years, and certainly in 2020 due to COVID-19, we have seen now more VV cases. And I think this is now sort of at match with the rest of the centers or at least busier centers in North America and the world, where probably 50% of the cases are those of VV ECMO. We also have started extending our VV support to airway surgery, thoracic surgery, esophageal surgery, and so on and so on. So we see a few more of those. And certainly now that we're popularizing this kind of support among our thoracic surgery colleagues, among our interventional respirology colleagues, and our ENT surgeons, people are becoming aware that they have an option of doing surgery without ET tubes and whatnot in their way. So this certainly, I think, will probably boost our VV program a little bit more. So you can see in 2020, we, and I think this number is off by a little bit as well, but the numbers have been climbing steadily and we've reached our busiest year. And from what I heard, it looks like we surpassed Toronto during 2020. Of those 63 cases here, and actually the total number is probably 70 cases if I remember correctly, but we had a significant number of VV cases that were utilized for support of COVID-19 patients. Next slide, please. Sorry for this busy slide, but this actually shows you a bit graphically as to what has been done in terms of our caseload. It separates the VAs, ECPRs, and others. I will later on talk a little bit about what we have achieved in terms of the number of consults and activations where we didn't put patients on. So in terms of survival, we report based on ELSO reporting principles, which is survival to decannulation. Then we also looked at survival at 30 days. Just to make it a little bit more realistic and I think fair in terms of what we report. Also, database is heavy on reporting survival to decannulation. I think that's probably not reasonable as we've seen in some of our cases, but the comparison that we're going to make are going to make a little bit more sense. So for us, our most successful groups are usually the VVs. We tend to have a very sick VV population. Our survival normally is in the vicinity of 60–65% in terms of our VV group. Recently, it's dropped down a tad because of the COVID-19 pandemic. Our best group generally is the VA group. So this is the group of patients whom we quote unquote catch in cardiogenic shock who need support prior to having a cardiac arrest. We report survival of these patients in decannulation to about 80% and survival very close to that, as a matter of fact. As documented in literature and elsewhere in the world, the ECPR group is the worst performing group, and in particular, the outside of hospital cardiac arrest has a very, very poor results. In terms of our complications, most of our complications occur in this group, and they are related to bleeding and leg ischemia. We were doing quite nicely up to about a month ago. Actually, we hadn't had a leg problem from quite a while, and then we had a run of 3 ischemic limbs in the last 3 ECPR cases, where due to patient habitus and whatnot, we had issues placing distal leg perfusion cannulae, and patients ended up with vascular complications. Our vascular group is currently quite unhappy with us for providing them that kind of business. Nevertheless, they've been quite supportive of us, and so on and so on. So I'm going to show you next slide, please. This is I've put in a little bit of there's a bit of a pediatric data here as well. Pediatric outcomes on VA are certainly better than those that we have. Again, this is not comparable data because the numbers are so much smaller in the pediatric group. Just to update you a little bit, our number of COVID supported patients is now 19 rather than 18, and we've added another VA case for a COVID patient. So our survival is actually a little bit better now than what you see. The reported literature survival is around 40–50%. So we're doing quite okay with that. Our COVID VV, non-COVID VVs, like I said, we tend to wait, I think, a little bit too long, and I'm trying to change this practice around here to boost up this number of 61% to decannulation to a little bit better. But we're certainly not far off what is predicted. Our eCPR obviously is what we need to improve on, and I'm not really sure that this is improvable based on what is being published. Our survival to decannulation ranges in the vicinity of 30 to 35%, and overall survival at 30 days, probably around 25 to 30%, depending on the year. In addition to this, in 2020, we received 13 consults, meaning 13 consults without activation of the team. 27 times the team was activated and did not perform cannulation. So we have about a third of false positives, I guess, in terms of our activation. So that's where we stand. Next slide, please. This is the survival based on the ELSO database. I've corrected this a little bit because the data from 2020 in ELSO was a little bit skewed. ECPR was reported with a survival of 41%, which nobody in the world achieves, by the way. Even the group in Paris, which is the busiest center on the planet, and they perform 480 ECPR cases a year. They report a survival of 35%. So this is where we stand. Our VV numbers are looking quite okay. Also reports a little bit higher than us, but this is without the COVID. So I think this will go down. This will go down a little bit. Like I said, I wish we can catch all of these patients before they actually have a cardiac arrest, because we do extremely well. And this is additionally very much a testament to the success of our mechanical circulatory support program in terms of short and long-term VADs. Where these patients tend to be sent for more of a definitive treatment if they're not weaned off VA. And again, ECPR, like I said, we are where we are. Next slide, please. So this is just to show you in terms of how well we're doing in terms of reporting in terms of supporting our patients and how long they've been supported. In general, as expected, obviously VV patients tend to be supported longer than VA patients. Our policy here is that at day 3 or 4 of VA support, we're looking for our ways out, meaning to provide more definitive support, because it is our strong belief that for cardiogenic shock and for failing heart, ECMO is not an optimal support strategy due to a high afterload that it provides. And it really is not a heart support, but rather a circulatory support. So we have a tendency to co-treat our patients with short-term ventricular assist devices, and then treat them definitively with either transplantation or durable devices. Next slide, please. This is our geographic distribution in terms of where we have placed our ECMOs. You can see the majority of them come from the intensive care. MGH has been a steady provider of cases for us. Cath lab somewhat less in 2020 than normally, but generally that's what we perform. Next, please. These are our response times. In terms of how soon we get the patient onto cardiopulmonary bypass from the moment a physician has activated code ECMO. As you can see, the best time for you to have ECMO is if you're in the ICU and somebody calls fast. However, if you actually look at around the world what is reported, we're probably 2 or 3 standard deviations below, meaning we're so much faster than most centers in the world in terms of our activation and on cardiopulmonary bypass time or on ECMO time. So I'm extremely pleased with the system, the way it's working in terms of activating us and our team getting to the spot. We're becoming quite efficient with ultrasound now, and the patients are placed on support very fast. As you can see, even at MGH after hours, our numbers are quite good. Next slide, please. So this is a very nice paper from Rob Bartlett, with whom I trained at the University of Michigan, who talks about where we head from here. And you know, things happen, and we learn from everything that has happened to us. I think you know, we became a little arrogant, I think, in the last couple of years when it came to our our complications, where we were doing quite well, particularly in terms of vascular complications, and we saw a nice lull in terms of our vascular surgery group involvement for leg ischemia. We've become more humble recently, as we've had some leg complications, and now we're looking into using smaller, higher profile, higher flow cannulae, particularly in our ECPR cases, to try to improve this and not to have it happen again. Obviously, the portability of the machine is leading to almost a need or an obligation to provide this technology and this type of treatment to patients all over Quebec, and not just in Montreal in quaternary centers. So we're working hard in terms of extending what is available at McGill to places like Charles-le-Moyne or St. Mary's or La Salle, Verdun, Trois-Rivières, Saint-Jérôme, et cetera, et cetera. These are only some of the centers that have reached out to us for help. Again, it is really my pleasure to present this to you and to show you how far this program has come. And I want to thank again to my colleagues who've made this possible, and certainly the groups from nursing and perfusion who've been extremely active in supporting our endeavors and turning this hopefully into something very important in the future. Thank you so much for listening to my presentation. I'll pass it over to Dr. Martucci, who seems to have joined us.
Gordan, thank you very much. I'm just looking at the time, and it's already 8:16. So, and I think the chat is starting to light up a bit. So, hi Joe, how are you?
Hey, sorry about that, guys.
No.
Bad luck, and
Yeah. Well, I'm sure you did the right thing with your patient, so that's what's important.
So Kev, I agree. I don't think I need to give my. I think giving my talk now will be a bit disruptive to the whole process. Yeah.
So I'm just. It's just we're going to have to go in about 10 minutes or less, actually. So maybe Gordan and David, you could unmute, as well as Christian, and I can just read some of the messages from the chat, if that's okay. So we have a first message from Dr. Musavi, cardiologist at Vic. Thank you for putting this together. The question is really about how is the administration helping expand the program to the MGH? I don't know who can take that on.
I'll talk about it, Kev. Yeah, Nagar, I really I share your sentiment about this, and I think it's extremely important that we it has been recognized that the volumes at the MGH is potentially going to increase, and has actually been increasing, in particular with EP still being there, and the trauma cases being there, and now the thoracic cases being there. We certainly have the expertise on the physician side there. Our most valuable resource that is limited is the perfusion department, and stretching perfusion over 3 sites, meaning Children's, Royal Victoria, and Montreal General, is currently not feasible. We have requested through the administration of the hospital, as a matter of fact, 2.5 full-time perfusionists to be recruited and hired in order to support not only the ECMO program, but cardiac surgical program and the program at the thoracic surgery department and so on. I'm just we would train the nurses, we would train physicians, but for the time being, our limiting step is the perfusion. I mean, I'm very proud to say that, you know, no case has ever been canceled due to lack of perfusion support. These guys have gone far and beyond to make sure that this happens. But we're doing our best, and I'm really hoping that you know, the administration is very much in favor of hiring a new perfusionist, and that would probably allow us to do some expansion to the general. But for the time being, and I think for the next 2.5 years, there's absolutely no perfusionists on the market to be hired. So that's where we unfortunately stand. But I agree with I actually very much endorse your question. I think it's extremely important.
So I would agree with the perfusionists. They do a great job. That there's no doubt about that. Next question was, what are the specific indications for patients receiving VV ECMO at the MUHC?
I guess I'll go. I'm sorry, who is this question from? Because I missed that part.
Thoracic surgery. It's called thoracic surgery. They
So
just want to know the indications for VV ECMO. I guess they weren't clear in the presentation.
So we're following the classic guidelines of ELSO, and these guidelines have been extrapolated now from both CESAR trial and EOLIA trials that have defined parameters in terms of Murray scores, PF ratios, duration of hypoxemia and duration of deranged PF ratio, and so on and so on. So we tend to follow the EOLIA trial guidelines a little bit more for installation of early VV ECMO. So we're looking at patients who've been ventilated for mechanically ventilated less than 7 days, who've been in the PF ratio of less than 80 or sorry, less than 60 or less than 80 for 6 and 8 hours, if I remember correctly, and so on and so on. We also initially used, in addition to that, obviously the age of the patient. We tend not to go beyond the age of 75. This occasionally does happen, based on the judgment of the treating physician. We exclude the patients who have comorbidities that would preclude them from being supported, such as advanced malignancies and so on and so on. So we're not using anything special. This has been narrowed down a little bit during the COVID era, and I think our age cutoff has come down certainly below 70 for COVID patients. But we haven't invented anything new that ELSO doesn't recommend.
Okay, good, thanks. We have a comment on appreciating your talk and good job from As Is, so that's great. We have a comment here from Dr. Devarenne concerning the scarce ICU resources and the fact that the patients are being sent to the Glen from other referring hospitals. And the impact that is on ICU access for other services, obviously including cardiac surgery, which tends also to get put on strain related to having a lot of ECMO in an ICU that also serves a large component of cardiac surgery and other services as well.
I mean, that's a very valid point from Benoit, and we've discussed this many times, and I agree with Benoit's ideas regarding a specific allocation of resources to ICU pertaining to ECMO cases, and I think we're heading that way. I don't know how soon we're heading that way, but the administration has been quite friendly to us. On the other hand, I have to comment that we tend to focus on patients who are acute in terms of limiting our resources in the intensive care unit, while we tend to forget that there are patients in our units who are at the end of life for years, and who we never talk about when we talk about resource limitations. So I think when administration assesses what needs to be done in order to allow these patients, who I think all deserve to come to the Glen and receive the best care that 2021 can offer, whether that's ECMO, cardiac surgery, mechanical circulatory support, respiratory medicine, or whatever, we need to look at what we do with the patients who get admitted here on a chronic basis. And I think that's where we suffer. We do not suffer from high acuity medicine and occupancy of our ICU beds. We suffer from patients, from patients who stay here for 500 days, who are 89 years old, tracheostomized, and brain dead. So I think our resources need to be focused on analysis of where the bed resources really are suffering.
Okay, Gordan, I don't want to get into that. But thank you for your comment. We have a lot of questions, so maybe if we could just keep the answer like really kind of tight and focused. I know I'm asking you a lot. We have another question from RJ Doonan, vascular surgery. Thank you for this great talk. Can you provide the survival to discharge numbers? So not survival to decannulation, survival to discharge for VA, VV, and ECPR.
The survival,
you have those.
Yes, I do. The survival, the discharge, we have a 30-day mortality, which usually coincides with survival to discharge. So for V ECMO, we're looking at, prior to the COVID pandemic, we're looking at survivability with decent neurological status at about between 60 and 65%. For our V VA cases, the patients who went home, even though 80% of them, they got decannulated in 2020, these numbers were a little bit lower in the previous years. So we're looking at 50% discharge to home. So VA prior to CPR, meaning cardiogenic shock patients and so on and so on. ECPR cases, we're looking at discharge, survivability to discharge around 21%.
Okay, thank you. I'm going to have to maybe parse some of these. I'm sorry. Okay, what is the survival rate after initiating ECMO? I think where you've been through that. Dr. Urgina asks, what would be the mortality related to patients once they have leg ischemic complications?
Depending on what the leg ischemic complication is and whether the mortality is related to ECMO or to the disease or to the leg, I certainly can tell you that you know, in the last several years, we've had a very, very few leg complications that have led to death. Unfortunately, in the last month or so, we've had 3 of them. 2 patients died from you know, I don't know whether that they died from the leg or the complication of ECMO leg disease and everything else, but it is certainly a contributory factor. And no study has ever looked at specifically mortality related to leg ischemic, because it would be a subgroup analysis, and it's very difficult to discern whether the leg ischemia was a direct cause of death.
Okay, so it's probably related somehow, but we don't really have clear-cut numbers on that one. Dr. Chicheri says, nice review, good team effort. Please comment on the use of ECMO in trauma.
Something that's in infancy, certainly around the globe, and it's probably a bit of a Star Trek effort right now. Some busy centers in Houston, Miami, and whatnot are using it for pulmonary contusions, cardiac contusions, and whatnot. We certainly haven't had experience here, Renzo, at all. I think maybe 1 or 2 trauma patients ended up on ECMO, and you know, these patients tend to survive because they're young and probably not because of ECMO. But we have really little experience. And I mean, if there's time, maybe one of the guys from trauma can comment on, based on the centers where they trained. But I certainly don't have any experience here or in Michigan for that matter.
Okay. I'm just trying to go. Dr. Kawaja asked, is there a committee? There are other centers that have independent committees that review on a regular basis ECMO for indications and futility. Do we have this at the MUHC?
Yes, we do. The ECMO committee meets every 6 weeks to 2 months. We present all the cases that have been, all the patients that were cannulated. We discuss their outcomes and try to put together quality improvement guidelines. So yes, there is such a committee.
Okay. Just a note from Jean. Jean, the perfusionist has put most of this data together that said that the survival to discharge data is not yet available for 2020 because some of the patients are still in-house. So I guess the 30-day may not be long enough to, yeah. Okay, there's another comment here. Dr. Razik, mostly trauma, PE, limited experience. Okay, so he's just commenting on that comment. So Dr. Razik says to us that most ECMO is for patients post-trauma PE. So not so much in the acute phase, I guess, is what Dr. Razik is saying. Yeah. Dr. Deveren, maybe just closing. Sorry, I'm just trying to get this. I'm sorry, it's moving around here. Can you comment on patients aged 87, 78, multiple comorbidities, being placed on ECMO? There seems to be very flexible application of inclusion criteria, varying a lot from one implanter to the other.
You know, it's difficult to say when a patient is in the cath lab and somebody is performing a procedure which they think is life-saving on a patient who just walked from home to have an elective procedure performed, and then the patient crashes and is put on ECMO as a rescue therapy. I can't comment on it, Benoit, because I like to empower the individual physicians to make rational decisions and reasonable decisions, which are in the interest of patient, the system, and everybody else, to do so. Occasionally, sometimes this is stretched, and we learn what we need to do. There were cases where patients who were refused for ordinary aortic valve surgery and were having TAVR done, and then were placed on ECMO as well. So we need to apply the guidelines as guidelines and not as rules. And yes, we learn, and sometimes we perhaps do the wrong thing. But I would like to think that that this is, if somebody puts a 78-year-old on ECMO in the cath lab, this is done out of the best intent, and that person deems is correct for the patient.
Thank you, Gordan. I mean, just from the chat, you can see the talk has generated a lot of interest. I guess my last question, maybe Dr. Martucci, will give him a chance to respond, is the data actually is skewed in the sense that the VA tends to do better than VV, and according to if you look at the also data, the difference is quite dramatic. Any reason to help us understand why the VA data is so much better in this institution than other institutions? And I'm wondering if it's because some of these patients are put on VA in the cath lab, where the cardiologists, the interventionalists are there, and they have their wires in, and in that kind of setting, it might have a better impact.
Yeah, thank you, Kevin. I think you're absolutely right. I think, when someone is put on ECMO or other percutaneous support in the cath lab, usually we're already halfway there because we have access, et cetera, et cetera. We have a team already on site, the patient's already prepped, et cetera, et cetera. So I think part of that success, or a large part of that success, has to do with timing. And having also people who are familiar with putting in cannulas and getting access, et cetera, et cetera. So I think it's multifactorial, but I think the big thing is you have a patient who is already primed, if you will, to get his access. The patient's already prepped, the nursing staff is already in-house, the physician is already there. And so a lot of that, I think, adds to the benefit that you see with the VECMO.
Kevin, there's an interesting question up here with, is it ethical to use ECPR during this time for patients with dismal prognosis? I'm not sure who this is coming from. Who's asking this question?
I didn't see that.
Okay. No, it's above Benoit.
Oh, I see. It's from an iPhone. Okay, yeah. Sorry, I missed that one. Go ahead.
Well, I mean, I don't know who's asking the question. It's a very, very interesting question, and I think it's quite good. Once again, I don't know. The word ethical is a very bad word to toss around. I think it's not ethical to use ECPR on a 32-year-old who comes in with a cardiac arrest, despite the fact that we're in the pandemic. And especially when we're intubating 88-year-olds who have COVID. So I think it's not unethical.
Okay, well, look, we're past our time. I'd like to thank all of you for not only attending, but with your chat and questions, and thank the presenters for their presentation and their collaboration together and teamwork, obviously. And we'll maybe have you back in a year or so to give us a follow-up and some data. So thank you very much, everyone, and have a good day, and we'll see you next month. Next month, we have a section on equity, and you should be getting a notice to that, but it's going to be again on the 4th Wednesday. It's at the end of February. So again, I hope everybody can attend. So thank you very much, everybody. Have a good day.
Thank you.